Hello and welcome everyone to the National Council of Urban Indian Health. Do I know our organization? Event Data Sharing and Data Use 101, Data Use Agreements 101. My name is Micah Grant Hunthrop, and I am one of the public health project coordinators here at NCUIH. We would like to thank you for volunteering your time today to participate in our event. We at NCUIH appreciate your willingness to learn from us and to share your personal experiences with data use agreements and data sharing. We do understand that this can be a sensitive topic. This is a safe place, and feel free to share as much as you feel comfortable sharing. There are no right or wrong answers, and we know that everyone is in a different place with capacity, so this is a chance for us all to learn from each other. Next slide, please. So again, welcome. We are very pleased that you could join us. Our discussion today is very important and will allow us to further understand the current landscape around data use and data sharing. If you do have any IT difficulty during today's call, please chat directly to Comms and Events, and River can assist you. And finally, if you could please put your name, UIO, or external organization, and any tribal affiliations into the chat box so that we can all get to know each other and count your attendance. Just a few bit of housekeeping before we begin. Please, if you have video capability, enable your camera, as this helps to create a more interactive environment. Also, please note that your microphones are muted, but you will have an opportunity during the event to provide any questions or comments. You can raise your hand at the bottom if you'd like to be called on, or just unmute if there is silence and pop in. Our chat box is being monitored as well, so please feel free to drop any questions or comments throughout the presentation, and we will address them at the designated time. Please note that this session is being recorded for education and quality improvement purposes, but your answers will not be published, and the information that you provide during our question and answer session will be used to further inform our research and programs. To begin, we'd like to provide a brief background on NCUIH. Our organization is a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives, AIAN, living in urban areas. NCUIH is a national organization advocating for the 41 Title V Urban Indian Organizations, or UIOs, under the Indian Health Service in the Indian Healthcare Improvement. We would like to acknowledge that this project is funded in part by TEFCA Legal Guidance for STLT Legal Team and Informaticians, and is supported by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views of or nor an endorsement by CDC or HHS or the U.S. At this time, we would invite you to save this link or scan the QR code. This will lead you to our event evaluation. Your feedback for the event is very important to us. We do take all of your comments into consideration, and they help inform our future work. So this is our agenda for the day. As you can see, it has already consisted of our welcome and housekeeping. We'll then hear from our subject matter expert, discuss some key differences in data use agreements for UIOs, and end with time for an open discussion and questions. So at this time, please join me in welcoming our subject matter expert for today, Adele Stewart. Adele is a senior manager at Double Lantern Informatics, specializing in regulatory impact analysis and commenting, data standardization, communications design, and training. Her work is informed by prior roles at tech companies in telecommunications and telemedicine, as well as time spent in Turkey with public health and education nonprofits. She's proud to hold degrees from the Emory University Rowland School of Public Health, where she graduated with an MPH in Applied Public Health Informatics, and the Georgetown University School of Nursing and Health Sciences, where she graduated with a bachelor's in human science. Adele also has extensive program management, coalition building, and grassroots organizing experience as the co-founder of Georgia Stomp, a health equity-focused advocacy coalition working on topics relating to menstruation. Since its founding in 2018, Adele has been asked to speak at national conferences and contribute to legal publications regarding the coalition's work. Now a 501c3 nonprofit, Georgia Stomp's membership has grown to include more than 35 advocacy, service, and professional organizations representing over 85,000 Georgians. Adele is deeply committed to leaving the world better than she found it and finds great joy in building relationships with like-minded colleagues and friends. And at this time, I will turn it over to Adele Stewart. Thank you, Adele.
Thank you, Micah. I really appreciate that. And I am deeply committed to making the world a better place and to meeting like-minded colleagues and friends. And so it's kind of with that in mind that I say it really is a privilege to be speaking to you all today. I'm going to jump right in. We're going to start with just a bit of context about data use. So as you likely know, the Health Insurance Portability and Accountability Act of 1996, or HIPAA, established rules that support the secure exchange of health data in ways that protect patient privacy. And there are certain purposes for which health information can be disclosed without modification, like treatment, payment, or healthcare operations. But there are other purposes that require data to be modified so that certain identifiers are removed. And this is called a limited data set. Now, because a limited data set isn't completely de-identified, it still requires that a data use agreement be put in place. And we're going to talk a little bit about data use agreements. These agreements help determine who is permitted to use or receive the limited data set, and they put certain guardrails on the use of that data. These include things like, what can the data be used for? What sort of protections must be in place? What do we need to do if something goes wrong? And so if you were to need to share data for research or public health or healthcare operations purposes, you would likely need to establish a data use agreement. We'll talk through some of the things you might consider as you begin walking through that process. But first, I wanted to cover a couple of terms you might see if you were to engage in the process of establishing a DUA. The first is permitted use or permissible purpose. This is just a long way of saying, how is the party who receives that data able to use that information? So that might be things like treatment or payment or healthcare operations, maybe public health activity, research, or when the data is about the individual requesting that data, that could be a permissible purpose included in the terms of the DUA. There's also the concept of minimum necessary, which I'm not a HIPAA expert, but minimum necessary is one of those concepts that are translatable across a lot of different areas of health data exchange, which really states that you should only be sharing the data that is needed and no more in order to accomplish the goal that you've set out to accomplish. So unless that exchange is for treatment or is about the individual requesting the data, we all are governed by this principle of minimum necessary when we're sharing information. I'm going to actually hand it over to Micah to discuss some specific considerations for UIOs when looking at data use agreements. Micah, I'll hand it to you.
Thank you, Adele. Yes. So we wanted to go over some clarifications around data use agreements specific to UIOs, as there are some, concerns for the patient population that UIOs serve. So data use agreements are essential for managing the transfer and the use of data, and especially with dealing with that sensitive information. And so these agreements ensure that data is handled responsibly and in compliance with legal and ethical standards. And so these are just a few of those key differences that you may want to consider when looking at regular data use agreements compared to UIOs. So in general, the purpose and scope is to outline that purpose of that data sharing, the types of data that is involved, and their specific clauses. For UIO specific data use agreements, they often include additional clauses to address the unique concerns of urban Indian communities, such as cultural sensitivity and community specific health data. As far as data ownership and rights, in general, DUAs will specify who owns the data and the rights of each party regarding the data use and publication. But for UIOs, they often include provisions that ensure the data remains under the control of the community and that any use of that data benefits the community involved. Privacy and confidentiality. In general, most data use agreements just include standard privacy protections to comply with regulations such as HIPAA. The UIO-specific ones often have enhanced privacy measures within their agreements to protect the identities and health information of the AIAN individuals. Cultural sensitivity. This may come as a shock to you all, but most data use agreements do not have any cultural consideration clauses or anything like that in them. But for UIO specific agreements, they include clauses that ensure that the data use respects cultural values and traditions of the AIAN communities of the data that they're using. The review and approval process, typically in general, it's reviewed by legal and compliance teams across both or however many organizations are involved in the data use agreement. But with UIO specific, they often require additional review by tribal leaders or community representatives to ensure alignment with community values and priorities. And then for sharing and reporting, data use agreements always outline how that data will be shared and reported, but for UIO specifically, they often include specific reporting requirements to ensure transparency and accountability to the community. All of these are just some things that you'll want to take into consideration when focusing on data use agreements in the UIO specific population. I'll pass it back to Adele.
Thanks, Micah. Many of you might have already encountered DUAs in your efforts to serve the populations that you do serve. But one thing that we wanted to outline are a couple of steps that you can take if you're working to decide whether or not you do need a data use agreement, because as we've noted, between HIPAA law and other laws governing the privacy and security of data, it can be a complex process. So Micah, if you don't mind advancing to the next slide, or River, excuse me. The first thing to do in determining if you need a DUA is to talk with the party you may be wanting to exchange data with, build that relationship, and work to determine, are you going to be the data provider or the data receiver? What purpose might you be using that data for, or might the other party be using that data for? And then gather the folks around who need to be involved in the review process or the signing of a DUA. And this might include your leaders, so maybe the tribal council or governing board or other community advisory boards. It might be your legal support staff who are able to review those agreements and understand applicable law, certainly better than myself, who I am not a lawyer. But one thing we wanted to really highlight here is that it's never too early to involve legal counsel, because reviews take time. And especially in considering the impacts of sharing data, you want to ensure that you've dotted all your I's and crossed all your T's. And not slowing down the process. So next, it might be helpful to involve the teams who are fulfilling requests for health records today, like a health information management department. If you happen to have one of those at your organization, they're the ones who really know today what boxes have to be checked in order to share information legally and securely and in a manner that respects, consents or authorization. So they're great folks to have at the table. If there are any data or informatics teams, like clinical informatics teams or technical teams who are able to support you with documentation about data ownership or data workflows, they're great folks to have at the table too. And sometimes involving those documents in the discussions, the design documents or workflow documents, can be a real game changer in helping everybody reach shared understanding. So those are excellent folks to have alongside you. And then, of course, your security or privacy officers who are aware of existing privacy protections and obligations and can add a level of understanding to the data use agreement negotiations. So with that, we're going to slightly pivot and start talking about TEFCA, the Trusted Exchange Framework and Common Agreement. This is a network, or refers to a network, that's being used today to support the exchange of data for select purposes. And I'll take just a brief step back and kind of note that, speaking as a patient, I know many of us will agree that our health information should be shared easily and securely with ourselves or our doctors or those who are supporting us on our health journeys when it's appropriate. And that this in turn will support better care and lower healthcare costs. But many of us have also had experiences where that hasn't been the case. Our information hasn't been available when we or our care providers have needed it. And so TEFCA is an effort for all of us to work to fix that so that those who need the information can access it in a responsible and trustworthy manner. Now, towards that goal, TEFCA was a solution that was proposed to solve that and other data exchange challenges. It was passed in 2016 as part of the 21st Century Cures Act, and it works to establish what I call the rules of the road for nationwide data exchange. There were requirements that were in place in the 21st Century Cures Act that required the two foundational documents that really support this new network as part of TEFCA. The first is the Trusted Exchange Framework. This is just a set of common principles that are designed to facilitate trust between health information networks and those who use them. Now, when folks voluntarily agree to the Trusted Exchange Framework, they're agreeing to principles like standardization, like openness and transparency, cooperation and non-discrimination, privacy, security, and safety, access, equity, and public health, all shared goals in facilitating nationwide data exchange in support of a better future. The other document that the 21st Century Cures Act provided a directive for is called the Common Agreement. Now, the Common Agreement is the actual contract that defines the baseline legal and technical requirements for secure information sharing on a nationwide scale. Who signs the Common Agreement? Organizations called QHINs. These are health information networks that have gone through a special designation process. They sign the Common Agreement and then create artifacts that participants sign in order to join those health information networks to begin participating in this data sharing nationwide. I'll jump to the next slide to go through some of the rules of data sharing under TEFCA. These include laws like those that already govern privacy or public health reporting, so respect for existing law. The Common Agreement also indicates that information can only be shared for certain purposes, which some of these will start to sound a little bit like the premises that we include in data use agreements. They indicate which privacy and security policies must be followed, and if there's a breach, notification that might be required. And they also determine that data must be shared in a way that is agreed upon. It's standardized so that once it goes from point A to point B, it can easily be used. There are some other rules that are involved in TEFCA, like how can disagreements be resolved, or what is the governance process like, and how can we update the TEFCA documentation in order to either expand the required purposes for which responses must be provided, or even perhaps add new health information networks to that qualified health information network list. But it's important to note that as part of data sharing under TEFCA, we have live data exchange occurring today. So with these rules in mind, we've been able to start sharing information across the nation by those who have voluntarily decided to participate. Let's pop to the next slide, River. Thanks. As I said, participation is voluntary, and parties that join can only exchange data that they have a right to exchange, like under necessary agreements or authority. It's another callback to our earlier slides on DUAs. But when organizations agree to the rules, they can exchange health data nationwide through this network of health information networks for specific purposes. There are 6 approved purposes today: treatment, payment, healthcare operations, public health, government benefits determination, and individual access services, meaning like a patient looking for information on themselves. Now, today in dark green, you'll see the only 2 information exchange purposes for which responses are required. So let's say 2 parties have joined a qualified health information network. So one of these specially designated health information networks that are part of TEFCA. And they want to, one of them asks the other one for information on a patient's care so that they can provide emergency assistance. The only responses that would be required would be a situation like that for treatment, or if the patient themselves have some sort of an application and they want to access data on themselves. The other exchange purposes, payment, healthcare operations, public health, and government benefits determination, today are just voluntary. So you can respond to requests for information to support those exchange purposes, but it's not required of participants. And we'll talk a little bit more about who those participants might be on the next slide. So, who's exchanging this information? Some examples of the parties who can share information through TEFCA and what they might share would be health systems or providers who, like in the example I used on the last slide, might be accessing or sharing data to support treatment or perhaps to reduce duplicate testing. You'll also see health IT developers that are participating. So maybe there's an electronic health records vendor that has joined a QHIN, a Qualified Health Information Network, and is using it to pass information through to their customers or their healthcare providers that might support treatment or access by individuals. I've even seen it with my own healthcare provider that has joined TEFCA, where now I have the access through my patient portal account to see whether or not there's information through other healthcare providers that I can pull into my patient portal. That's individual access as I've seen it in my own life. There's also federal agencies. So TEFCA can be used to facilitate data exchange in support of like Medicaid case management. Public health, there are a couple of public health exchange purposes that have been approved for response. That includes maybe providing information, immunization records. So a healthcare provider could send immunization records to public health, or perhaps the public health authority could use TEFCA to support disease reporting with receiving electronic case reports or seeking additional information in support of contact tracing. Another example, federal agencies, the CDC might be able to receive information from public health authorities if there is a nationally notifiable disease that they need reports on. Now, anything outside of treatment and individual access today is not necessarily hypothetical, but it hasn't been happening a lot yet. The vast majority of exchanges done today are in support of treatment and are largely occurring between health systems or health providers and other health systems or other providers, perhaps through their health IT developers or their health information networks that they've already joined. So I wanted to provide you with some examples of what might be possible through the other exchange purposes. Let's pop to the next slide. Thank you. So what does this actually look like? I am apologetic on behalf of everybody in informatics right now because there's just not a great diagram that we can show you that makes it really simple to see how the health information networks exchange information. But I'm going to do my best. So bear with me and feel free to submit your own if you're feeling creative. The first is this diagram here on the right that shows the general governance structure and data exchange structure through TEFCA. So at the top of the diagram, you see the Office of the National Coordinator, which is part of the Assistant Secretary for Technology and Policy. They are responsible for defining policy and governance, as you might expect from an HHS agency or body. The ONC has taken a step to designate a nonprofit, the Sequoia Project, as the recognized coordinating entity. This is the body that provides oversight and the governing approach. They also host a bunch of resources to be made available so that if you have questions about TEFCA, you can go out to the recognized coordinating entity's website and they'll provide a lot of great information. They've been working with the qualified health information networks that's directly below that umbrella to make sure that adequate testing have been performed, that paperwork looks right, that the infrastructure that will actually facilitate the exchange of data from point A to point B is as we would all expect it to be and aligns with the trusted exchange framework and common agreement. QHINs actually sign the common agreement, their contract for their responsibilities that they must abide by, with the recognized coordinating entity, with the Sequoia Project. So they're an important intermediary between the Office of the National Coordinator and the actual exchange that's taking place. Now, today there are 7 qualified health information networks. These are existing health information networks or health IT developers that have agreed to the TEFCA rules and gone through really rigorous performance testing to show that they can exchange information nationwide according to the standards that we've all said are important are important and make data exchange, easy and streamlined and feasible. So there are a couple of names you might be familiar with, like eHealth Exchange, Epic Nexus, Kanza, No2, Commonwealth. I'm going to forget some now that I'm on the spot. Health Gorilla, and I'll have to think of my last one if I've missed any of them. But there are 7 QHINs live today, and they are actively recruiting participants and sub-participants to join their network. So we've established an understanding of the qualified health information networks, the folks that are actually facilitating the exchange of information from A to B. But we've got to have people or networks or organizations that are a part of the QHINs, and those are the participants and sub-participants. These could be, but are not limited to, a health information network, a health system, maybe a state or regional health information exchange, maybe a payer or a federal agency. They're anyone who has entered into a contract or signed the terms of participation to participate in a qualified health information network. And the relationship between participants and sub-participants can be different depending on who's joining what. Let's jump to the next slide and see if I can't jump into that a little bit further. So I started from the top down on the last diagram. I'm going to go from the bottom up on this one. So sub-participants and participants join the QHINs in order to exchange information with other organizations that have joined a QHIN as part of TEFCA. So these are all folks who have said, I have a need to exchange information for treatment or other purposes, like medical providers, health system EHRs, pharmacy system health ITs, maybe even an app that a patient uses to manage their medical records. They join the QHINs, and then the QHINs are actually the ones who are exchanging the information from point to point, making sure that the necessary documentation is in place, that the technical standards are being followed, and that everybody has an endpoint or a directory ID where you can be sure that when you're asking for information, it's going to the right person and you're receiving it to the right destination. There's a network of all these QHINs. So here, this diagram with only 5 is not representative. We have 7 QHINs today. And the understanding is that TEFCA will continue to grow over time. The recognized coordinating entity is still accepting requests or applications to become a QHIN today. And I don't know if they will plan on shutting that down at any point in time. So if someone or an organization rather is prepared to exchange information, they can apply to be a QHIN and go through that rigorous testing process in order to be part of that network. Let's jump to how do you actually join TEFCA if you were interested in participating. The first would be to identify the QHIN that's best for your organization. Typically, we'll recommend that you reach out to your health IT developer, like your electronic health records vendor, or perhaps an existing health information exchange or network that you participate in today. And reminder, there are 7 QHINs to choose from. And I don't know if I have them all on a slide here, but they're available in some of the resources later, linked out later in the deck. Once you've determined which QHIN will meet your needs, you will sign the participation agreement. And so this includes the TEFCA terms of participation, those rules that all parties must agree to in order to share data through the network. You'll also determine if there are any persons or entities that use your tools or services to send and retrieve electronic information. And you'll ask them to also agree to the terms of participation. So this, in my experience, is like if there's a healthcare provider and they maybe have a community connect provider who uses their electronic health record system in their own operations. If the original party can't bind that community connect provider to a legal agreement, that's how we would determine that that party would be a sub-participant and they would need to facilitate that terms of participation agreement. Finally, depending on the QHIN, there might be additional configuration and testing requirements as set out by the QHIN or the participant, depending on your level of involvement. Finally, you're responsible to provide information to be listed in the directory. So just like we used to have phone books in the past, we now have these digital directories that provide the technical node or endpoint where the information should either originate from or be received to. And I want to make sure I haven't missed anything in my notes. Yes, I think that is all I wanted to cover on this slide. So we can pop to the next slide, which has the additional resources. I mentioned the recognized coordinating entity. The Sequoia Project, do a great job of providing regular opportunities to get more information on TEFCA if you still have questions. They meet every month on the 3rd Tuesday of each month. Unfortunately, that happens to be today. So there was an RCE monthly meeting just a few hours ago from noon to 1 Eastern. On these sessions, they provide helpful information about updates to the network or things that you might expect with updated documentation that may be released over the coming months. And they also have a question and answer session every time. So it's a great place to go and offer up your own questions if you have something that applies to your UIOs joining of TEFCA. They also provide past recordings and slides. So if you wanted to go in and get a jump start before next month, you could absolutely do so. I'll also note they're very responsive. And so if you had a specific question and you didn't want to wait for the next monthly meeting, you could send them an email and their contact information is available on their website. They also have a handful of flyers or other artifacts that might be helpful, like this TEFCA for Executives flyer that we've linked here, or a list of questions to ask your potential QHIN. I think what's important for this group is that you not only review the questions that they recommend you ask your potential QHIN, but also keep in mind some of the questions that we talked about or considerations as part of data use generally, and have those in your have those handy when you're ready to have those conversations with potential QHINs or the participants that you may participate under. And then finally, the ONC, the Office of the National Coordinator, has a website on TEFCA, which includes past webinars, blogs, and handouts where you can go out and capture information that may be helpful for you. With that, I've spoken at you for a long time, and I know it's quite important for us to make sure that we have an open discussion and answer questions if we have the ability to do so. So Micah, I'm happy to run through these, or I'm happy to hand it back to you and simply serve as a resource.
I can happy to lead the discussion and we'll have you just available to answer questions as needed. Thank you so much for that presentation. It was very informative. At this time, we are going to transition into that open discussion. So we are going to be asking some questions of you all today, but then we will give you all time to ask questions of us as well. So our first question, and feel free to either come off of mute or drop your answers in the chat. But before today, were you aware of TEFCA? And if so, what information about TEFCA did you receive and from whom? Okay. Seeing some no's in the chat. We've got a lot of no's in the chat. That's okay. I'm glad that you were able to learn something new today. We have a yes, but didn't fully understand it. Totally understand. It's a complicated topic. Took me a while. Awesome. Well, feel free to keep commenting or come off of mute if you have any additional comments about that question, but we'll move on to the next one of have you had any discussions with your EHR about joining TEFCA in the future? I'm going to say guess that for most of you is probably going to be no, since this is your first time hearing about TEFCA. Does your UIO have any concerns about joining TEFCA or any other nationwide patient data sharing? Any other concerns about that? Sure. Definitely a big topic and something that would you would want to discuss with your entire organization.
Hi, Yvette. I see your question there. I'm happy to jump in, Micah, if that's appropriate.
Yes, of course.
So it depends on the purpose for which the data might be exchanged. For instance, if there's maybe a public health purpose with a limited data set that might be exchanged, there may or may not be an additional data use agreement that would need to be in place that's not already established. It really is, as Micah said, important to talk to the folks within a given UIO and the party that you're exchanging information with. Really, TEFCA doesn't, for most folks who are already participating in any sort of health information exchange, there's not a major change in what's happening here. It's just it's like going on a new road, like going on the highway instead of going on going on the interstate instead of going on the highway. So it's just a new path that information can be exchanged.
I don't know if you saw the question from Rochelle. She shared that they're newer to using the EHR, so I'm not sure how TEFCA would make things easier for them. Do you mind explaining some provider benefits or organization benefits for TEFCA?
Absolutely. So right now, using an EHR, you have access to your own information, the information that your organization has created for the purposes of caring for your patients. What a health information exchange does, and what TEFCA does as a network facilitating that health data exchange, is makes available information that other organizations might have about those same patients. So let's say a patient has recently moved from out of state, and you need to understand, what immunizations do they have at with their last provider, and update your own records. You can ask the patient, you can query a state immunization information system, or in this case, you could simply query another care provider. Yes, thanks, Rochelle. Thank you. I'm glad to know that that's helpful. Knowing that today it is really early days on TEFCA, and folks are still identifying why they might use TEFCA versus other methods of exchanging information. That's an ongoing conversation. So I think use cases that are important to you all are important for all of us to hear. I also see Sarah's question about the difference between an HIE and being a QHIN. So Sarah, typically health information exchanges are at the state or regional level, but they do very similar things to what TEFCA is meant to do. TEFCA is just intended to exchange information on a national scale. So when we have information done exchanged regionally, we're only getting that coverage of the area that HIE captures. When we create a network of these networks, which is what TEFCA is meant to do, we're able to kind of boost the power or boost the amount of information that's available with certain trust provisions in place. Now, the qualified health information networks that are the key party that facilitates information exchange through TEFCA, they've gone through rigorous additional testing to make sure that they're exchanging information using accepted standards that everyone is agreeing to as part of TEFCA. And these support modern data exchange. Right now, it's not a lot different than what you might see through a regional health information exchange in terms of the technical standards that are in use. But over time, TEFCA hopes to move to a data standard called FHIR, FHIR. And that's meant to really robustly exchange discrete data through modern technology. So it's a way to get information quickly and precisely from point A to point B.
Would you describe TEFCA as an alternative to a DUA, or is TEFCA incorporates DUAs, or kind of two separate things?
TEFCA complements existing DUAs. So it simply provides you with a new mechanism for exchanging the information that you already have a right to exchange under permissible law or agreements.
We have a question. Do you know how they are transmitting? So we have it's CCDA slash
Today it's
HL7.
IHE, so they're using the CCDA, though, as I said, eventually the goal is to move to HL7 FHIR over time, but IHE is not going away. It'll be here for a long time. Do QHINs have agreements that brought in the HIEs under their network? It's a great question, Sarah. So some qualified health information networks already, before they became QHINs, were already massive health information networks that supported data exchange that, went far and wide, but didn't have national coverage. They may have had certain customers due to certain technologies that they used, or they might have had certain customers based on existing relationships with electronic health records. So each QHIN serves a little bit of a different purpose depending on just their history of their organization. When the QHINs became QHINs, they had to sign the common agreement, which puts very specific conditions on the participation of TEFCA so that everybody can be assured that those, principles and security provisions are in place before they start exchanging data through this network. Health information exchanges and other participants who are part of qualified health information networks who didn't want to participate through those health information networks should have been given the option to not participate through those networks. So for instance, I know that there are health organizations that were asked whether or not they wanted to participate through a certain qualified health information network when that qualified health information network was finalizing its application process to become a QHIN. So when they were still just a QHIN, but wanted to be able to be considered part of the QHIN network. And so those healthcare providers were given the option, just as other health information exchanges were given the option to either opt in or opt out. Can a UIO negotiate changes to their participant agreement with a QHIN? There are certain provisions that cannot be modified. The terms of participation are really locked tight, but that doesn't mean there aren't other provisions that can be agreed upon in a framework agreement. So most of the qualified health information networks have their own requirements for participating in the QHINs that are unique to them. Those are negotiable, and but you would expect to see an exhibit or some specific section of that agreement, that framework agreement, that is not modifiable. And those are the terms of participation for TEFCA, because we all want to make sure we're all playing by the same rules. But that's kind of the floor, I would say. The framework agreements that can be negotiated would be negotiable. Not to repeat myself. Thank you. These are great questions.
Yes, this is a lot of great questions, a lot of great discussion. We do have a couple more questions for you all and our attendees. So one question, just as a follow-up, do you all feel after this event that you may be prepared to have discussions with your EHRs about TEFCA? And if not, what additional resources or needs do you think that you would need in order to begin those conversations? Awesome, thank you. Got some comments in the chat. Totally understand. Thank you. Well, do you have any ideas about how you might use TEFCA or how TEFCA might benefit your organization? Some really broad questions, but just anything that you are thinking about how this could be beneficial for you.
Coordinating care. Yeah, I totally get that.
Well, feel free to keep putting questions in the chat or any other comments that you might have about TEFCA. Or before we move on, Adele, were there any other questions or comments that you wanted to add for this discussion?
I just wanted to make sure that if anybody had any additional questions, I'm glad there were questions that came through in the chat, because I wanted to make sure TEFCA is a complex concept. And so if you have anything else you wanted to ask, even if it feels like a basic question, I'm happy to answer those. As Micah said, it's complex. It takes a lot to understand sometimes, especially when it's not reality for your, when it's not in front of you. I'm a very tangible person. Non-identifiable information can be shared for general statistics. That would be helpful. Renee, I might actually ask for a little clarification if you don't mind, if that's okay. Data for trend analysis. Right now, research is not a permitted, well, not even right now. Research is not a permitted purpose through TEFCA. We can go back, Micah or River, do you mind if we go back to the slide with the approved purposes? So today, one or two more. today we're really looking at the exchange of individual data. So not like bulk data exchange. And the information that is exchanged or is approved for public health purposes today, as kind of a follow-up to Yvette's question, falls under either electronic case reporting or query and response. So these would be specific public health queries, for instance, in support of like immunization information systems or contact tracing. So the scope is limited. I want to make sure that I speak in turn. So I'm going to pull up the standard operating procedure for public health and make sure that I tell you verbatim what the approved purpose is. So one moment. Okay. Electronic, I failed to mention electronic lab reporting as well. So there are public health exchange purposes that include electronic case reporting, electronic lab reporting, and and I can put this resource in the chat so that I'm not hogging it all to myself. Let's see. I want to make sure I get the level 1 treatment exchange purpose correct. Immunization data, vital records, prescription drug monitoring, hospital capacity, chronic disease, and other registry reporting is what they outline today on page 5. So it says it is available for any allowable public health purpose, but that those are the purposes that they anticipate expanding to. Know that any request for public health right now does not require a response. It is completely voluntary. The only requests for data that require a response are treatment and individual access service. So if I, as a patient, want information on myself, and then if we're supporting the care of an individual patient. So these types of requests, like other mechanisms for public health requests, are not required. They're simply allowable. I hope that answers both of your questions. Does that help Renee and Yvette?
Can I just unmute and ask? I guess I got a little excited when I was thinking about nationally the connected records to know different health information, and how cool it would be not to know specifically which individual, but regions or numbers of tribal or non-tribal people that have maybe heart conditions or have diabetes, those kinds of trends, to just have, just because if it can nationally be electronically at someone's fingertips, and I get that it would probably be difficult to do it globally. I don't know. It just seems exciting to have all of the access to all those different facts and all that data, and not be able to just use it to be able to compare and contrast and use global data.
I understand. I as curious individuals, it can feel really exciting to think about the potential of electronic health information when exchanged for good. I do think that TEFCA has some guardrails on it right now to make sure that it's only being used for very specific purposes. Just during these early days, I think it's important to kind of take it step by step, but I hear you. I have a real heart for data as well. I see one last question from Yvette about if a UIO doesn't have an EHR, how do they connect as a participant to get, for example, immunization information on individuals they serve in their programs? So Some organizations, I don't know whether this is the case for UIOs or not, but some organizations have joined health information exchanges or health information networks today in order to support their population health activities or their work, whether that's retrieving information from immunization information systems, like for school purposes, to make sure that the kids are immunized before they get in the classroom, or there are other use cases that I'm going to blank on under a time crunch. But those organizations, if the system, the health IT developer that they are engaging with to receive electronic health information have elected to join TEFCA, they could also elect to receive that information through TEFCA or exchange it, provide it if they're entering in data into these systems. So an EHR is simply one form of health information technology that can connect to a QHIN or connect as a participant or sub-participant to participate in TEFCA. I mentioned earlier, like pharmacy health information technology systems, or perhaps eventually even laboratories. There's a lot of different ways to exchange health data. But with that, Micah, I'll hand it back to you to close things up. Thank you all so much for these great questions.
Yes, sorry to cut short the Q&A. Oh, Rupert, can we go back 2 slides? One more, so sorry. This one, yes. Just wanted to share that we do have an upcoming resource that is going to be available on our website, and we will be sharing it out after this event. Our policy team has created a lovely document that's an FAQ on TEFCA specifically for UIOs. So this resource will be coming soon to our website and to an inbox near you, so that you can have, hopefully this will help answer any other additional questions that you may have. And we will be sharing, as I said earlier, any resource links that were shared today, we will be providing after the event as well. Move on to the next slide. This was another resource from Adele that she wanted to share, just a sample public health exchange. We will share this out as well in our key takeaways document after the event. Next slide, please. So if you are feeling a little overwhelmed from today and still have some additional questions, please feel free to reach out to us through our one-on-one technical assistance. NCUIH does offer one-on-one TA to member UIOs, and that can include all of these things listed here, but also can include data use and data sharing. So if you have any specific questions, we're more than happy to assist you. Next slide. And then thank you all so much for attending. This has been a really great event. We appreciate your feedback and your comments and questions. It's been so good to hear from you. Thank you. Looks like we do have another question of how UIHI work plays into this. I will unfortunately have to get back to you on that one. That is something that I will have to take away and head back up to our senior leadership to get that information. But Eudora, this is my email address, and I will drop it in the chat as well. Please feel free to email me this question, and I will work to answer you directly, because unfortunately I don't have that information off the top of my head. And other than that, please feel free to please take our survey. We do welcome all of your feedback. It is very, very beneficial for us. We get to learn what's working for you, what's not. We use it to help inform our future events and work so that we can make sure that we are serving you all in the best way that we can. And thank you all so much for your time. We at NCUIH appreciate you volunteering not only your time, but your thoughts, opinions, and suggestions. Please feel free to drop any final questions or comments in the chat. And otherwise, please have a great day.